I'm Mabel Jung, and you're watching continuing coverage of the World Healthcare Congress here in Washington, D.C. We have a lot of interviews to share with you, and in our studio right now is Pamela Greenberg, who is President and CEO, Association for Behavioral Health and Wellness. Thank you, Pamela, for joining us today.
Thanks for having me.
And you're participating in a panel on parity. Can you focus a little bit on what you've been talking about on that topic, and what are the takeaways that you'd like to share with attendees?
Sure. So we had a panel yesterday with several speakers who talked about mental health and addiction parity. And it was an interesting conversation. We started off just by talking about how long we've been discussing this topic. So in the early 90s, we started talking about having the mental health and the substance use disorder benefit equal to the physical health benefit. So that would be in terms of the money that you pay in a co-payment be the same, or the day or any day or visit limits that you had, like how many days you could be in the hospital for in a year, equalizing all of those. And that discussion started in the early 90s and hopefully ended in 2008 when a large law passed, the Mental Health Parity and Addiction Equity Act. And at the panel yesterday, some of the health plans talked about how they're implementing parity and kind of doing the analysis. You have to get the information from the medical side and the information from the behavioral health side and compare the two to make sure that things are indeed equal. And then we also had somebody from the state of Massachusetts talking about their implementation of parity. And it was interesting because there was somebody from North Carolina in the audience who was very much interested in what the person from Massachusetts had to say, because their state hasn't been really implementing it as aggressively as Massachusetts had.
Okay. It sounds like there were some initial challenges that were addressed, but there are always new ones on the horizon. What are some of the where is some of the focus going to be for the association? Other areas that have need that you need to look at?
Sure. So, one of the things, and just to kind of relate it to parity, is, and we talked about this yesterday as well, so we have parity now in the benefit, but parity to what? What is the quality of care that's being offered, and is there an access? Is there access to the providers that individuals need? So it's kind of beyond parity, moving to is there access for people who need it, whether it's residential treatment or outpatient treatment, and what is the care that they're getting, and how are we evaluating that care? So parity still remains an issue of importance, but starting to kind of move outward a little bit. We also focus on something called 42 CFR Part 2, very technical, but that is a substance use privacy law that requires the individual to authorize any disclosure of their substance use record. So on the medical side, you have the Health Insurance Portability and Accountability Act, HIPAA. And that allows records to be shared for treatment and payment and healthcare operations. But for substance use, you always have to have a signature before you can, anybody can see the data. And this is a real barrier to integrated care. Because if you don't have the signature, for example, you were just telling me about how your son, when he got his wisdom teeth out, was prescribed an opiate. Well, if your son had a substance use disorder problem but hadn't signed off to allow providers to see the information, that dentist wouldn't have known that he had an addiction problem, and maybe let's say he was in recovery, but the dentist wouldn't know. He'd still prescribe the opiate, and that means somebody in recovery would have gotten a prescription for opiate. That's like, candy in your hands, and how do you say, no, I don't want that?
Right. Now, as long as we're on that topic, how does this growing issue with opioid use relate to maybe a shortage of behavioral health providers? I mean, do you have enough people to treat those people that are facing that kind of addiction?
Sure. So the shortage very much affects people with an opioid problem. The most common treatment for someone with an opioid addiction is what's called medication-assisted treatment, or MAT. But you have to be you have to have a special certification to be a MAT provider, and there's a shortage of them in the sense that many doctors have signed up to prescribe medication for opioid disorder, but what they do is maybe they treat their friend or a family member, right? So they've gotten the certification to treat an individual, but not just to say my door's open for anybody with an opioid addiction. And then in some areas, somebody commented yesterday that there just simply weren't enough. So sometimes there are providers, but they're not taking all comers, so to speak. And then at other times, there just aren't providers in the area to treat these individuals. And medication's not the only treatment. Also therapy, a combination of both is really what's seen as the best treatment for someone with this problem.
Do you see consumers being more actively engaged with treatment or access to treatment, especially on the behavioral care side?
Very much so. I think I've seen it more maybe in the last 2 or so years. I think part of it started with the whole transparency movement and trying to make consumers more aware of how much things cost, right? And posting, encouraging providers and hospitals to post information about how much something costs. So I think it started there with, wow, do you know my doctor charges $150 for this visit? I only pay $5, but I saw what the insurance company gets. And then moving from there to wanting to be a part of the decision-making process and really becoming more of a savvy consumer, if you will. They're not just, the old school kind of style of you have a substance use disorder problem, this is what you need to do, okay, and go off and do it. It's more now, well, what does that mean? And what are my treatment options? I don't want you to tell me one thing. I want you to tell me my options, and I want to discuss with you, like we are right now, what I want to choose, which option I want to choose. And the other interesting thing in behavioral health is that families have been involved in the treatment for a long time, where I don't know that that's as common on the medical side, but in behavioral health, family involvement is very important, and our member companies recognize that as well and make sure that the family's involved. It's not all the time, every step of the way, but maybe in an initial visit and some kind of check-in. And when you think of it again, if somebody has a substance use disorder, it's important, right, if they're in recovery, that they don't go home to a refrigerator full of beer and wine and things like that.
Right.
So the family awareness of somebody's problems and illness is very important.
Do you find more education resources for family members now, perhaps more than before?
I think there have been those resources out there for a while. I think maybe what's newer is families' desire and kind of looking for those resources and asking for those resources. So I think that they've been there for a while, but they've maybe been on the shelf, and now they're on the table.
On the front, yes.
Yeah.
What is another takeaway you really want to leave with attendees at this meeting? A lot of different things are being discussed in a changing healthcare landscape, but we shouldn't forget what we might need to know on the behavioral health and wellness side.
Sure. Well, I think another thing that we didn't talk about is telehealth and the importance and use of telehealth. And I don't want people to think that telehealth is just kind of an easy solution, right? Because it's a telephone or a computer monitor, and it's not a person in front of you looking at you. So therefore, some people I think therefore think that telehealth is bad. But telehealth can reach people who can't otherwise be reached, right? Whether it's because they live in a rural area, or whether they're too depressed to get out of bed. Or they could live in Los Angeles where it takes 2 hours to get anywhere. And so the use of telehealth too has helped us with the workforce shortage that you mentioned earlier. So maybe you don't have a psychiatrist in your area, but you can access one through the computer, or the primary care provider could call a psychiatrist and use kind of telehealth in that way. And so I think to not kind of push telehealth aside, but realize the importance and how in behavioral health with a workforce shortage, telehealth can really be an aid to us and another good way to receive care.
Great. Pamela Greenberg, thank you so much for your time today.
Thank you. Thanks for having me.
And thank you for tuning in. Stay tuned for much more content on its way. I'm Mabel John.